Hello everyone, welcome back. Oh, one second. Hello everyone, welcome back. So let's start today class. We have to finish up the eye today. So let's take a look at these eyes. Okie dokie. So today we are going to speak more about the eye. We are going to speak about more specificities of the eye. How the eye works. Basically we have the idea of your pupils becoming small, your pupils becoming big, all of this stuff. Guys, if I put a flashlight into your eyes right now, what will happen to your pupils? They are going to constrict, absolutely. So they are going to close up, constrict. So instead of constriction, pupillary constriction, there is another way of saying it. We say meiosis. Meiosis is when the pupil becomes smaller. Mydriasis, it's when it becomes bigger. Okay, so let's just associate this with sympathetic and parasympathetic with a little story. The sympathetic nervous system is the fight or flight, the active type of system, the thing that you utilize when you are scared, for example. So if the lion is following me and I need to run away from him, I should be able to observe more light around me. I should be able to see more stuff, to be able to find a new route, to be able to escape from the lion. So should I do meiosis or mydriasis? What do you think? I need to run away and observe all of the area around me. Mydriasis, absolutely. Okay, I am laying late at night after I had my heavy meal and I'm laying on my bed and I just wanna relax and fall to sleep at my dark room. Meiosis, that's it. Okay, good. So meiosis constriction, and it's mediated by the parasympathetic nervous system, also known as the rest and digest system. What cranial nerves are considered to have a part in the parasympathetic nervous system? Does anybody remember which cranial nerve are associated with a parasympathetic nervous system? Somebody says 9, what else? So it was a year, if you remember, it was like a year. 1973. So cranial nerve number 10, 9, 7, and 3. So now we are going to speak about the meiosis process. So we are going to be more specified. We are going to speak about the cranial nerve number 3. Does anybody remember from which portion of the brain stem does the cranial nerve number 3 come out from? The midbrain, absolutely correct. So I hope you remember 12, 11, 9, and 10 come out from, which is the last 4, coming from the medulla. Then we have 8, 7, 6, and 5 coming from the bones. 3 and 2 comes from the midbrain. The third one comes from the anterior portion of the midbrain, while the trochlear, or the cranial nerve number 4, comes out posteriorly from the brain. Okay, now let's speak about the meiosis process. This leads to constriction of the pupils, is parasympathetic. It has the following neurons: the first order neuron and the second order neuron. The first order neuron is located as something known as the Edinger-Westphal nucleus, and it's located exactly at the midbrain. So this is a cross section of the midbrain. This is the Edinger-Westphal nucleus, this guy, and it is responsible for cranial nerve number 3, the parasympathetic portion. Why I'm like speaking about so many things in the same time, like relating to them? Well, and why I'm saying cranial nerve number 3, the parasympathetic portion? Because if you take the parasympathetic nervous system, is it only parasympathetic or is it parasympathetic plus motor? Yes, absolutely. So it is motor as well. So if you take a look at the third cranial nerve, if you remember, it has medially it has the motor function, and laterally it has the parasympathetic function, or peripherally it has the parasympathetic function. I told you this is really, really important, and in a second you will understand why. Of course, this is the nerve, right? So if I have an aneurysm here pushing the nerve down, which fiber will be affected first? Is it the parasympathetic fiber or the motor fibers? What do you think? The parasympathetic fibers, absolutely. This is why in case of a nearby aneurysm, like a posterior communicating artery aneurysm pushing against the cranial nerve number 3, the patient is going to be suffering from blown out pupils, meaning mydriatic pupil, okay? So their pupils will be mydriatic in that case, initially. Eventually, if the aneurysm keep getting bigger, what will happen? It's going to affect the motor portion. Absolutely correct. So if it keeps getting bigger, it's going to affect eventually the motor fibers. Okay, good. All makes sense. That's nice. So we can add up a few more things here. So let's think about it. They say for us the following. Okay, done with this moment. Now this moment. So in this patient, the situation is going to be as follows. There is a little artery. I just want to change the color since we just spoke about this topic. We need to finish it up. There is an artery going exactly right here, okay? There is like inside of it. If we have a patient who's diabetic and he had like a micro infarction here at this location, which symptoms are going to happen first? Of course, there is an artery here and there is arteries here as well, okay? So the peripheral is supplied from totally different innervation than the motor, just to keep that in mind. So the peripherally, it will not be affected, it will be normal. So initially it will be motor, right? Well, that's cool. So are you telling me if the patient has a cranial nerve number 3, parasympathetic system, parasympathetic nervous system symptoms, it means it's an aneurysm or a tumor that is pushing the nerve, versus if the patient had motor dysfunction, it means that it could be an infarction. That's exactly what I'm saying right now. Okay. So let's continue with this. So we have the Edgar-Westphal nucleus, which gives fibers into the cranial nerve number 3, and then what happens? As you can see, he's giving these fibers, and they are going here to the ciliary ganglia. And from the ciliary ganglia, it's going to keep moving up all the way until it reaches the ciliary body and supplies the sphincter pupillary muscle that help. What do you think? Is it going to be mydriasis or meiosis? Parasympathetic, come on. Meiosis, absolutely. So when this is going to fire, it's going to lead to meiosis, which is why? Because it is parasympathetic nervous system stuff. 1973, it's the 3. Okay. So, okay, that's cool. Like any other parasympathetic nervous system, the presynaptic is much more taller than the postsynaptic fiber. Okay? So, what they write here they are speaking about the pupillary right reflex, which means like when I put a flashlight into your eyes, they will become meiosis. So I have a question. I have a patient here. There is one eye, and this is one eye. So this is the pupil, and this is the pupil. Which disease this patient have? If you can see the whole iris, which disease the patient? If you see a patient and you look at his eye and you can see the whole iris, what does he have? If you can see the whole iris. Like this. This is a more fancy eye. So the eye normally should look like this. When you look at a human being, you should see his eyes like this, not like this. Like this, it's normal. But this, excellent, is exophthalmosis. This one is exophthalmosis, which is associated with thyroid problem, right? Okay, anyway, let's forget about thyroid for a second and worry about the things that we have to worry about. So we have the patient here. There is 2 eyes for you guys, and I put a flashlight in his eyes. And after the flashlight, if I put the flashlight to this eye, okay, the flashlight is going to this eye. What is going to happen to this eye? What do you think? So this is left eye and right eye. What is going to happen to the left eye? Meiosis, absolutely correct. It's going to be meiosis. Nice. What about the right eye? If you put a flashlight in a patient left eye, what is going to happen to its size? The answer is meiosis. It's going to become smaller. But what about the right eye? What will happen to the right eye? Meiosis as well. Meiosis as well, guys. You can try it at somebody at home. Just bring a flashlight, put it in one eye, and look at the other eye. There will be also meiosis. And you're like, wow. So even what you can make, and it will be even more cooler, put a barrier between the two eyes. Like put your hand and put the flashlight only into one eye, okay? And cover the other eye so it will not see the light. What will happen to the other eye? Also meiosis. So this is kind of bizarre. Why this have happened? This is our topic for today. This is why this have happened. So let's read and try to understand how this occurred. Light in either the retina sends a signal via the cranial nerve number 2 to something known as the pretectal nucleus, which is located posteriorly. So this is the pretectal nucleus. So pretectal nucleus is going to receive a fiber, which is located in the midbrain and eventually is going to activate something called our friend, the Edinger-Westphal nucleus. The Edinger-Westphal nucleus is responsible for the parasympathetic fibers that lead to pupillary constriction. But take a note, the pupillary constriction, see, it's going where? Like it comes from the pretectal nucleus, the info, but it sends to both sides, right? And this one as well. So if you flashlight the right eye, let's put a flashlight here, and the light will come, boom, 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 and come here. And when it reaches here, it's going to activate both of these nuclei, meaning the pupillary constriction is going to happen at both sides, okay? So the next thing is going to be as follows. So pupillary constriction at both sides bilaterally. So the first eye that is affected is going to constrict, and the consensual eye, which is the other eye, is also going to constrict. So the result, illumination in the first eye is going to lead to bilateral pupillary constriction. Okay, good. Mydriasis, dilatation. So this is mediated by the sympathetic nervous system. So first order neuron, second order neuron, and even a third order neuron. This one is a little bit tricky. I hope I can find okay, it's here. So it's a little bit more complicated than you think. Why? Because it has 3 neurons and the pathway is much more longer. I mean, this pathway was like, boom, that's it. Nothing much. And in the case of the reflex, it was even simple, not that difficult. So basically, in the case of reflex, let's just describe it again. The light was pushed here. It went into the eye, to the pretectal nucleus in the midbrain. And then that sent fibers to the both Edinger-Westphal nucleus, not one, both of them. They sent info to the ciliary ganglia, parasympathetic nervous system, cranial nerve number 3. The fibers are located in the nerve peripherally, and then they are going to lead to meiosis of both eyes. Okay, this is important, and that will help you understand in the future which pathology it's related to. Mydriasis, however, it's more complicated. It starts from the hypothalamus. So the hypothalamus have the main sympathetic nervous system center, and from there is going to go to something known as the central of Budge. Central of Budge is located between the C8 until the C2, and yeah, well, basically exactly right here. This is the central of Budge. So again, the fibers comes from the hypothalamus. Hypothalamus is a part of which brain? Was it the midbrain, the diencephalon, mesencephalon, or medulla, or the bones? The hypothalamus, what was it from where? Do you remember? Not the medulla. Hypothalamus is a portion of the diencephalon. Okay, let's revise these. So the diencephalon is the thalamus and the hypothalamus. Diencephalon is thalamus and hypothalamus. Under it, we have the midbrain, which is also known as mesencephalon. Under it, we have the what? The bones. And under the bones, we have the medulla. Okay? The medulla have the olives and the pyramids. The pyramid is the corticospinal tract. I repeat, the thalamus, hypothalamus, your retina, and your posterior pituitary gland, all of these are portion of the encephalon. So after the nerves have reached this central of Pudge, this is the neuron. So this was first the neuron from the hypothalamus. Let's move on with it. So from the hypothalamus to the central of Pudge in the spinal cord, from C8 until T2, basically in the end of your neck. The second order neuron starts at the central of Pudge and it exits at the T1 to superior cervical ganglia. What is superior cervical ganglia? Let's take a look at that. So I hope that they show it. They do. Nice. So the second order neuron has started here. Boom. It's going up all the way until it reaches your superior cervical ganglia, which is a portion of the sympathetic ganglia that exists paravertebrally. Okay? And after that, it's going to send the third neurons, which are located here, to keep going, and then something really interesting will happen. At the external carotid, near the carotid sinus actually, they are going to divide their fibers. Okay? So from the third neurons, the sympathetic fibers are going to divide. One portion will go to the sweaty glands of the face. One portion will go to the smooth muscle of the eyelid and to the pupillary dilator muscle. And the last one will go to the sweaty glands of the forehead. Why I'm even telling you about this? Well, just let's imagine somebody with a Bankos tumor. What is a Bankos tumor? It's a cancer that can affect the apex of the lung. So if the apex of the lung is affected, this will get destroyed, just right here, okay? So if this is destroyed, you will not have basically sweating of the face. What do you think? It's going to be two side or one side? Absence of the sweating of the face. One side, absolutely. Okay. And can you dilate your pupils anymore? Do you think? Nope. So meiosis and anhidrosis so far. And the eyelid, smooth muscles are going to be messed up. So can you open your eyes fully? No, so we call that ptosis. So this is meiosis, ptosis, anhidrosis. This is known as Horner phenomena. Okay, so I would like just to associate these two pages together. That's what I just did. So it exits from the T1 to the superior cervical ganglia, travels along the cervical sympathetic chain near the lung apex, so the lung apex tumor can destroy it. Subclavian vessels as well. The third neuron will form a plexus around your internal carotid. So internal carotid artery dissection is going to affect the sympathetic fibers. If I was you, I would write the following note. In case of lung cancer, of the apex of the lung, we will have Horner syndrome, meiosis, ptosis, and hydrosis. In case of internal carotid artery aneurysm or dissection, we'll have the same. And then it travels through the cavernous sinus. In case of cavernous sinus thrombosis, we'll have Horner syndrome also. And enters the orbita along the long ciliary nerve to the pupillary dilator muscle. Okay, sympathetic fibers also innervate the smooth muscles of the eyelid, minor retractors. That's why when they are dysfunctional, the patient have ptosis. And the sweaty glands of the forehead and the face, and that's why when they are dysfunctional, the patient is going to have anhidrosis. If we go down here, we see something called Marcos-Ghun pupil. I hope you remember, guys, when we spoke about the prostitute eyes. In which disease did we see the prostitute eyes? It was in syphilis. You are absolutely correct. So this is kind of similar. Basically, but it's kind of the opposite, actually. So let's take a look what it says. It's also called relative afferent pupillary defect. So let's try to remember what happened in syphilis. If I put a flashlight in a lady who has syphilis, what is going to happen? Nothing. What about accommodation in a syphilis lady? Okay, yes, that's correct. So, Marcus gun pupil is different. However, people confuse them together, but they are not even related. So, when the light shines in the normal eye, we have two eyes, okay? Again, so this is the pupil inside of them. Big and beautiful. So, now, when you light the eye into a normal eye, there will be constriction of, let's light it again at the, let's say right eye, left eye. So we are putting the light now at the right eye. So the right eye is going to constrict, done. This is after, of course, constricting, and the other eye is also going to constrict. Why? This eye is normal, okay? This is the normal eye. So you will have constriction of the ipsilateral eye and the contralateral eye, which is also known as the direct reflux and the consensual reflux, the other eye reflux. That will be normal. Why? Because you just put the light at the normal eye. Okay, let me just shift this from here to here. Okay, I don't see any harm of this. Let's just shift it. Okay, let me just hide the light. I hid the light from here, and now I'm going to put the right here. This is a diseased eye. Let me tell you exactly what is diseased in it. It's the optic nerve, okay? The optic nerve is the problem. The optic nerve is messed up. Okay, like for example in multiple sclerosis, if you remember, cranial nerve number 2, which is optic nerve. Does it have a Schwann cells around it or oligodendrocyte? Oligodendrocyte is considered to be a central nervous system. Okay, we have agreement so far. So the optic nerve is messed up here. So let me actually just do this. Okay, this nerve is messed up in the left eye. So when you put the light here, what do you expect to happen? Exactly, vice versa. No, it will not constrict. This nerve is messed up. It's not working, guys. Okay, so you put the light here and you look at the pupils, and it was this size, and now it can be the same size or a little bit even bigger because it cannot see. So what happens? Look, when the light is a swang, so you put it to the affected eye, this one, to the affected eye, both pupils are going to dilate instead of constrict because of impaired conduction of light signals along the injured optic nerve. Why they have dilated? Because actually they did not do they put the full story, but I erased it. So remember, initially we put the light here. So both of them have constricted, right? Now you have swung the light to the other side. So both of them are going to dilate again, okay? Both of them are going to dilate again. Basically, they are dilating from the constriction that was caused by the initial movement, okay? So initially, you vasoconstricted. Remember, both of these are connected together. So this is constricted, and then when you go to the affected side, it's like he cannot see in it because the optic nerve is messed up. So they will just become normal, mydriatic. Okay, so they write here, when the light is swung to the affected eye, both the pupils will be dilated instead of constricted due to an impaired conduction of the light signal along the injured optic nerve. It's associated with optic neuritis, which can be seen in multiple sclerosis, as we said, and optic neuropathy like giant cell temporal arteritis, right? Remember, in these ladies, they had a granulomatous inflammation of their internal carotid artery branches, mostly the ophthalmic branch. Now, Horner syndrome, not Horny syndrome, it's Horner syndrome. Horner syndrome, this patient is going to have ptosis, anhidrosis, and meiosis. So, the sympathetic innervation is going to be messed up at some point, doesn't really matter where. So, Okay, before I continue, can somebody tell me where is the hypothalamus located? I mean, which portion of the brain, please? The diencephalon, absolutely correct. Nice. So, sympathetic denervation of the face will lead to ptosis, slight drooping of the eyelid because of affection of superior tarsal muscle, which is the retractor of the eyelid. So, the eye is going to drop. Anhidrosis, absence of the sweating, and the flushing of the affected side of the face. Guys, sweating is a good thing because it helps you to, well, get the temperature out. So if not, your face will become flushed. Meiosis, exactly, it's cool you. So if you don't cool you, it will become hot. Meiosis, pupil constriction because the midriatic, the sympathetic is not working. Associated with lesion along the sympathetic chain, the first order neuron here, it can be like from here until here. So until you reach the second order neuron, along this pathway, you can have pontine hemorrhage, lateral medullary syndrome. Lateral medullary syndrome? Huh. Which cranial nerve was affected in that one? Do you remember, guys? Lateral medullary syndrome, medulla oblongata. Which cranial nerve comes from the medulla oblongata? So that must be 12, 11, 10, and 9. Oof. But they are saying lateral. How do we differentiate between lateral and medial? I mean, which cranial nerve is coming from lateral? Which cranial nerve coming from medial? Do you remember how we differentiate between that? You divide by 12. So the only one that divides by 12 is number 12. That means this is medial. And the other 3 is lateral. Like somebody said, number 11. You are correct. So the patient is going to have affection of these 3 cranial nerve. Good. And if you remember, I keep telling you, medially, the motor function. Laterally, the SS, which is the sensory and the sympathetic. Okay, not always true, but in general, this is the case. Spinal cord lesion above the T1, like a Brown-Séquard syndrome, which is hemisection, basically cutting half of the spinal cord. And the other thing that can also occur is a late-stage syringomyelia, in which it can, basically the syrinx could compress the sympathetic fibers at the first order neuron in the brain. Okay, because it can like get big from the central canal, big, until it can compress the sympathetic chain located at the lateral column. The second order neuron, we have the stellate ganglia, and it can be compressed by the Bankus tumor, which is a tumor of the apex of the lung. It does not both upper and lower motor neurons. Nice. Okay, so the third neuron, which comes actually from the superior, from this superior cervical ganglia itself. It could be because of aortic dissection. Who's most likely to get aortic dissection? Carotid dissection. Who gets carotid dissection? Somebody once told me it's people who like have extreme hypertension. For the USMLE, this is possible, but it's the non-correct answer. The correct answer is somebody that get not atherosclerosis. I will tell you who. The people who get this thing is Will Smith. Why? Oh, no. Will Smith himself. No. What was the name of the guy that was slapped by Will Smith? Chris Rock. Exactly. So it happens after really bad slap. So please no. Not the elevation. No. That when you slap somebody really hard, there is high chance of getting a carotid dissection. Okay? So this is for you. Carotid dissection. So in the USMLE, it will be a bar fight or somebody who got slapped really, really bad. Okay? So that lead to carotid dissection. So the carotid dissection is really painful, guys. It's ridiculously painful. And the patient is going to be complaining of, oh my God, I got slapped and now it's the pain. I feel like it's tearing and it's in my neck and I feel it's going up to my face. That's carotid dissection. You need to fix it right away. If you don't, there is high chance the patient is going to die. Anhidrosis is usually absent. A lot of people ask me why. The answer is simple. If it's in the third order neuron, the problem is going to be basically right here, right? So it's going to spare the first fiber, which are the ones going to the sweaty glands. So the patient will not have the anhidrosis in case of a third order neuron affection. First order neuron, hypothalamus. Second order neuron, located in the spinal cord at the area of Put and Budge, center of Budge. And finally, the third one at the superior cervical ganglia. So now we'll take a 10 minutes break. We'll come back. We'll speak about ocular motility, cranial nerve responsible of the movement of the eye, and the visual field defects and the cavernous sinuses, and finished up with intranuclear ophthalmoplegia. So see you guys in 10 minutes. So let's continue with the eye. So ocular motility. We have 6 main muscles, actually 7, but 6 main muscles that controls your eye movement. I remember seeing this chemical formula, and I was like, this is bullshit. It does not make sense. At least for me. I don't know. If this works for you, it's amazing, but it does not work for me. So just understand the idea. Guys, when I say rectum, what is the rectum? What does the word rectum mean? Straight. Yes, regardless of the fact that gay people like it, but it's straight. So the word rectum, it means straight, okay? It doesn't matter where you see it. It's in the colon, rectum is straight. In the eye, rectus is straight. The muscle of the abdomen, when you say rectus abdominis, it means it's a straight muscle. So the word rectus means straight. Okay, so if this is the eye, it has 4 straight muscles. So it has a muscle. I'm just looking forward at the eye, of course. So there is a muscle located here, okay? Of course, this is just an anterior section because it's kind of difficult to see it, but basically just imagine it going posteriorly, okay? Or like, okay, something like this. And, okay, trying my artistic. Yeah, so this is the superior oblique. This is the inferior oblique, okay? And this is the medial oblique. Oh my God, superior and inferior rectus, medial rectus, and lateral rectus. So these rectuses are pretty simple. If I contract the superior rectus, your eyes is going to look, this is contracting, this is relaxing, so the eye will look upward, right? Okay, if I contract the medial oblique, so this is contracting, this is relaxing, meaning you will look medially. Pretty simple as that. So all of these muscles, according to which one it contracts, it moves. So yeah, cool. The 4 rectus muscles are pretty easy. They are straight muscles, as you can see. Superior rectus is straight, and it's simple. Well, what about the superior oblique and the inferior oblique? They are a little bit confusing, guys. So that's why I want to put this idea in your brain and then build on it. Superior oblique make you look down, inferior oblique make you look up, okay? Superior oblique make you look down, inferior oblique make you look up. This is the general idea. Now we speak details. I repeat the general idea. All of the rectus muscles make you look to their side, but the oblique muscles make you look at the other side, meaning superior rectus make you look, you're right. The superior rectus will make you look up or down? Up. Superior oblique will make you look, yes, down. Superior oblique will make you look down. Okay. So whenever we speak about a rectus muscle, the movement is going to be the exact same side as the muscle. But when we speak about an oblique, it's going to be vice versa. So the superior oblique, let's try to understand how this happens. So there is this little bony structure known as the trochlea, okay? And it just connects the muscle. So if we imagine that you have contracted this muscle, look what will happen to the eyeball. This is contracting, right? It's going to rotate and go down, okay? It's going to be rotating and going down. So again, this is gotten to this side, so it's going to rotate down and look downward. So the eye will start looking here, right? So this is superior oblique. Inferior oblique, vice versa. So now you must know each cranial nerve and what do they supply. I like always to start with the third cranial nerve. Why? Because it supplies all of them, except two. So we have superior rectus, inferior rectus, lateral rectus, medial rectus, right? And superior oblique and inferior oblique. Okay, let's make it quite as simple as possible. So, superior, inferior, and medial rectus, all of them are supplied by fourth cranial nerve. Okay? So, if I just take a different color, I'm going to take red. So, superior rectus, inferior rectus, medial rectus, and inferior oblique, all of these will be supplied by the third cranial nerve. Nice, so we have only two to memorize actually. So all of the eye muscles are supplied by the third cranial nerves except two. That makes it easy, yes. Which cranial nerve except the cranial nerve number 3 do supply the eye muscles? Do you remember? Number 4, no, number 2 is for vision. I'm speaking about the motor function of the movement of the eye. It's number 4, that's correct. What except number 4, number 6, okay? So, no, facial is not responsible of movement of the eye. It can move the orbicularis oculi muscle, which is the eye, like the eyelid and the stuff around the eye. But speaking about the eye movement itself. So the abducens, yes, cranial nerve number 6. It abducens, ABD, abducens. What will be its function? Its name is abducens. Abdul? No, abducens. Abducens abduct the eye. So make it look laterally. So that will be lateral rectus. So cranial nerve number 6 will be lateral rectus. Okay, that's it. It make you look away. The last one is going to be cranial nerve number 4. And since he's the last to go, is going to be superior oblique, which makes you look down. Okay, let's say that your cranial nerve number 4 is messed up. Can you look down now? Can you look down? If your cranial nerve number 4 is destroyed, can you look down? Pretty difficult, pretty difficult. I know some of you is like, but the inferior rectus is still functional. Yes, but not as good. So it will be more difficult to look down. Since it's more difficult to look down, can you go down the stairs? Nope, that will be the patient complaint. They cannot go down the stairs. And yeah, that will be the patient complaint. Okay, so in such patient, what do you think? I will draw 2 forms of eye. And you will tell me which one will be this patient, okay? So, is this patient is going to be... Okay, just a moment, because I need to think about it before I draw it. So this, he has a problem. Okay. So, or... This is variant number 1, variant number 2. What do you think? Which one of these two do have a problem in cranial nerve number 4? That is correct. No, cranial nerve number 4, it will be 1 because he is unable to look down. Guys, he's unable to look down, okay? He's unable to look down. Okay, so the second guy here, I told him to look to this side, but he did this. That means his cranial nerve, which cranial nerve of this eye is messed up? Somebody said the 3. You are right. The one who said the 3, you are right. Why? Because it's adduction. Adduction. If it was something like this, however, if I told him to look this side, and it was something like this, you will be like, which cranial nerve is defected in this eye? Abducens, number 6. Yes, because it abduct the affected eye. Okay. So let's take a look what they write for us. So they write, we have superior rectus, inferior rectus, lateral and medial rectus, superior oblique, inferior oblique. So cranial nerve number 4 innervate the lateral rectus. Number 6, lateral rectus, which is the abducens. Trochlearis sublies the superior oblique. And the third one is the rest of them. Chemical formula known as LR, which is like lateral rectus, cranial nerve number 6, superior oblique, cranial nerve number 4, and the rest of them will be cranial nerve number 3. If it works for you, good for you. So this is all of the eyes and their movement. So you can see the inferior oblique help you to look in and up. Superior oblique down and in. Superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. Okay, so this is how they help us to move our eyes. Obliques goes oppositely. So left superior oblique and inferior oblique tested with the patient looking to the right. Why you make the patient look to the right? So when we make him look to the right, so if we say that this is his right eye, this is his left eye. When you make him look to the right, he's already looking to this side. So you have excluded all of these. Done. You just have to check these, okay? When you ask him to look up and he cannot look up, that's a problem of the inferior oblique. If you ask him to look down and he cannot look down, that's a problem of the superior oblique. So blowout fracture. This is a pretty common question in the USMLE. They show you a picture of this, and the lower orbital border, which is this one, is destroyed. And the question comes, oh, which muscle was entrapped? So orbital floor fracture, usually caused by a direct trauma, which is basically a punch to the face in a bar fight. A direct trauma to the eyeball or the intraorbital rim increase the risk of inferior rectus muscle injury and or orbital fat entrapment. It may lead to an infraorbital nerve injury. What is the infraorbital nerve? Well, basically, if you take a look at the face, this is the nose, of course, there is a little hole here known as infraorbital foramen, which through it passes the infraorbital nerve. Okay, so now we speak about each of the cranial nerves more deeply. If you did not get what I spoke about here, this is your second chance of gaining what I just spoke about. So, which cranial nerves, just write them down, are parasympathetic nerves? Yes, 1973, which is 10, 9, 7, and 3. Okay, good. Which cranial nerve is responsible for the eye movement? I'm speaking about the eyeball movement. Third cranial nerve, what else? Fourth and sixth. Okay, which one is responsible for the abduction, which means looking away? 6. Awesome. Which one is responsible for making you, that's a tricky question, looking, which one is responsible for allowing you to look inward? Adduction, I mean. The third cranial nerve. Excellent. Which one is responsible for allowing you to look down? You can't choose multiple nerves. Which one allow you to look down? The fourth cranial nerve and also the third one, but yeah, both of them. Okay, good. So now we try to understand each nerve, how does it work, and all of the story. So, cranial nerve number 3. We have agreed with each other that the cranial nerve number 3 has both motor and parasympathetic fibers. Parasympathetic fibers are in the periphery, motor are in the middle. Cranial nerve number 3 has both motor, which is centrally located as you can see, and parasympathetic, which is peripherally located as you can see, and we can have injury to it. The injury, there is a whole 5 reasons, actually more. So yeah, the first one is ischemia with a pupil sparing. So what's up with this problem? What occurs exactly? Basically, the blood vessel is going right here, guys. Okay? So when he's damaged, the main area to be affected in case of ischemia is this. However, the parasympathetic output will be perfecto, nothing with that. So the pupil will be spared, nothing will happen to the pupil. Only the motor fiber will be messed up in case of ischemia. Who's most likely to get ischemia of this guy? It's a diabetic mellitus patient, okay? No. There will be no pupil affection, nothing with the pupils. So the motor output is the movement of the eye. Remember? The rectus muscle, the oblique muscle, this stuff. This is the motor movement. But the parasympathetic activity, in case of ischemia, is spared. Spared means it will not be affected. So only the motor movement will be affected in case of infarction of the blood vessel, which happens in diabetes mellitus patient. So ischemia, pupil sparing, motor fibers affected much more than the parasympathetic fibers, since the parasympathetic fibers are far away. Okay, ankle herniation. Onkos, I heard this somewhere. Well, the onkos was responsible for the ending of the like the main center of the olfaction in the brain. Remember, it was a portion of your temporal lobe, and in case of herniation, you might get a coma. It can, if we say that this is the onkos, and it has herniated, it's going to push what? The motor or the parasympathetic fibers? What do you think? Parasympathetic fibers. So can I, how to check if somebody has ankle herniation? By looking into his eyes. It's possible. You can look at his eyes, and if it is dilated, it means that this patient has it. So you can see how it is dilated here. Okay? So, okay, makes sense. So, posterior communicating aneurysm, sudden onset headache can occur in that case, and this patient is going to like in case of aneurysm, sudden headache can occur in this patient, and also initially it's going to be the parasympathetic fibers affected. Cavernous sinus thrombosis is a big topic, but basically what I want you to know that proptosis will happen, which is a blowing up eyes to you, and also affection of all of these cranial nerve. Why? So I don't know if it exists. Oh, okay, it exists. So you can see here the cavernous sinus. This is the cavernous sinus. Inside of the cavernous sinus, we have the internal carotid. There is a cranial nerve located near it. So how do we know which one is what? Easy. 3, 4, 5, 5, 6. Okay? So actually this is 5, 1, 5, 2. So this is the 3, 4, 5, 5, and 6. These are the cranial nerve going inside of the cavernous sinus. In case of internal carotid artery dissection or internal carotid artery aneurysm, what is the first cranial nerve to be affected? No, guys, it's abducens. Look, number 6. It's located just next to it. So if this is going to dilate, it will be the first to be hit. So the abduction will be messed up in that case. So let's take a look what they write for us. They say cavernous sinus thrombosis can lead to involvement of all of these cranial nerve that is located inside of the cavernous sinus. The first one to be affected, however, will be the 6th cranial nerve. Midbrain stroke can lead to contralateral hemiplegia. Okay, don't forget please that it can affect basically all of the motor fibers of your eye, mostly because the blood vessels will be the most likely to be affected. So motor output to the extraocular muscle affected primarily by a vascular disease, like in diabetes mellitus, which is, if you remember, glucose becomes sorbitol, and the sorbitol can be degraded into fructose. However, some tissues don't contain basically the enzyme that help to convert sorbitol into fructose, making an accumulation of sorbitol, like our eye. So it will have plenty of sorbitol there. Due to decreased diffusion of the oxygen and other nutrient into the anterior fibers from the compressed vasculature that reside outside of the nerve. So let's try to understand what does this story says exactly. So yes, there is a blood vessel here, but there is one more blood vessel that is located where? The main one, actually. It's like the coronary arteries, guys. The coronary arteries, were they inside of the heart or outside of the heart? How does the coronary artery pass? Is it inside of the heart or outside of the heart? Yes, but they do have this thing. Okay, so let's put a thrombus here. The area between this blood vessel and this blood vessel, how do we call it? Watershed area. Absolutely correct. So the watershed area is the first to become destroyed. Okay, so the idea is like this. They write, the signs of dysfunction of the motor stuff is going to be ptosis. Why? He is unable to control his eyelid. So he will be having this looking down and out. Why? Because he cannot adduct his eye. Well, basically his cranial nerve number 3 is screwed. So who takes control? Cranial nerve number 4, which make you look down, and the cranial nerve number 6, which make you look out. So you start looking down and out. Parasympathetic output, the fibers on the periphery are the first affected by compression. So the compression can be from posterior communicating artery aneurysm or ankle herniation. Okay, so signs will be diminished or absent pupillary light reflux in that case, because the parasympathetic fibers are not working, and that will be a blown pupil, which means big pupil, mydriasis basically. And if it progresses and you destroy also your motor function, you will get the down and out gaze. Down because of the cranial nerve number. What makes you look down? Which cranial nerve? 4. What makes you look out? Look out, guys. Look out is abduction. Abduction, which is 6. Yes. So let's speak about the cranial nerve. I'm sorry if I said up. I'm sorry. So cranial nerve number 4 damage. Pupil is higher in the affected eye. Why? Because the cranial nerve number 4, you just said, it makes us look down. So if it cannot look down, it will be looking up. So characteristic head tilt to contralateral unaffected side to compensate for the lack of intrusion of the affected eye. So you cannot intrude your affected eye, which will make you tilt your head. The whole head will be tilted to the side. Why? Because the patient will be trying to compensate to make him look straight to the person in front of him. So you cannot see the floor with the cranial nerve number 4 damage. So you cannot go down the stairs and you cannot read. This is super common question in the USMLE. I mean, going down the stairs type of thing. They keep telling you about somebody who cannot go down the stairs and tell you what's up, and you have to think about this. Cranial nerve number 6, palsy, it affected eye is unable to abduct, meaning looking out. So it will be looking in, okay? And this displays medially in a primary position of the gaze. Okay, so guys, in all of these diseases, you must treat the underlying cause, okay? And that helps in the treatment. It could be entrapment, and sometimes you can release the muscle. Most of the pathologies can be fixed, plus or minus. That's what I want you to take home. So the next thing we are going to speak about is going to be the visual field defect. The visual field defect is quite a huge topic. So let's start with them one by one. This thing you must master. So you have your right eye and you have your left eye. This is your visual field, okay? So the visual field defects, basically you have 2 eyes, you can see your visual field. So in the first one, logically, it's one eye totally like it cannot see. So probably it's a optic nerve damage. Can you tell me which pathology is going into your brain, making you thinking about an optic nerve damage? Which pathology can lead to an optic nerve damage? A tumor. Okay, tumor is good. Multiple sclerosis is also possible. Okay. The next pathology is going to be as follows. Bitemporal hemianopsia, pituitary lesion, and gray water is affected eye. Yes. I'm not sure what do you mean, but if you are saying that is this fibers made of white matter or gray matter, the answer is white matter, guys. Gray is affected. Yes, exactly. On the picture, the gray area is the affected portion. Okay, it's the affected portion. You are right. So this is a blind, basically. Okay, so yeah, cranial nerve, check, blind. The next one, optic nerve affection. Well, I really hate this picture, so I must draw it myself in a different way. So let me just do this. Take it here. Come on, open quick, 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 quick. Quick. Oh yeah, come on. Okay, good. So I did this so I can draw the real thing because this is not 100% true. They are lying to you. So let's see what actually happens. So what I want you to do is to divide this into halves. Okay, it's okay. That's too much, but no problem. Okay, can we just make it a little bit smaller? Okay, good. So let's make it black. Okay, nice. So the next thing is as follows. So from the visual fields, you can see that we have two areas, right? This area, we consider it to be, we say temporal visual field, temporal visual field. And this one, we consider it to be nasal visual field, nasal visual field. Okay, so the picture from this area is going to come in here, and the picture from this area is going to come here, okay? Nice, so we got it. We have some areas coming here and there. What's next? So, from this area, the vision is going to come like this, coming. Na. So it keep going until it reaches here. Okay, nice. So what about the other area? The other area is going to be as follows. So it's going to go through here and then comes here and then goes here. Okay, cool. So what about the other side? The exact same story. Let me just make it in red. And you will understand why I'm explaining all of this. It actually has really important clinical significance. So it goes like this to the same side basically, and then it comes right here. And this side will go like this and then comes like here. So if I destroy this area, let's follow the fibers and try to think what will happen. So this is destroyed. The first fiber to be affected is this guy. Okay, so let's follow him. It's affected here, here, here. So this guy here, here, and here, and here. So which portion of the visual field will be affected? Is it the temporal portion or the nasal portion? What do you think? Temporal portion. Okay, let me repeat what I just said. I'm saying some person had an optic chiasm destruction. The optic chiasm destruction must have done a pathology to some nerve fibers. So the nerve fibers have gotten the image from the temporal visual field, and then the image has came down and hit this medial portion of the eyeball, and from there the fibers went all the way until the optic chiasm. So basically I tried to go from the optic chiasm backward to know exactly which visual field was affected. Was it the nasal portion or the temporal portion? The temporal portion is the outside portion, the lateral portion. The nasal portion is the inner portion, okay? So if you did not understand, maybe now you can. So let's try to, yes, temporal hemianopsia on the right. So now look at the red fibers. So I'm going to do it on the other side for the sake of understanding. So if I just follow the red fibers, this one, right? Let me just follow it to see where it will end. Okay, so it's just going up, up, up. Okay, so it also ended at the temporal portion. That means that now I will be unable to see the lateral areas. And that explains why in chiasma optica lesion, I have bitemporal hemianopsia, which is inability to see these areas, right? It's the type of person that you say, oh, well, his vision is super narrow, don't speak to him. Yep, he has bitemporal hemianopsia. So let's keep it going. The optic tract. Just follow the drawing I just gave you already. So let me just clear some of this. Ah, shit, that was too much. Okay, let me redraw. So just remember, it boom, boom, coming to this side, passes the chiasma optica and go down here. And from this side, it will go to the optic tract. So in case of optic tract lesion, before I speak about it, the chiasma optica can be damaged because of a tumor, for example, like a pituitary adenoma. Okay, or craniopharyngioma as well. So optic tract lesion will destroy this guy and this guy. Let's follow them. I don't know if it's nasal or temporal. I have to follow them. So let's follow the black one first. Okay, so follow. I highly advise you to learn how to draw it, so you will have just in the exam to follow it and you can get the answer. Follow. Oh, okay. So we are at the nasal area. So the nasal area at the temporal lobe, at the right eye will be messed up. So this is messed up. Okay, perfecto. So if we put two eyes here, the right eye, so far we know that this vision will be messed up, right? We are good with that. Let's take the other portion. So the red fibers, let's take a look at the red fibers. The red fibers, okay, let's follow. Keep following it. So following it, and following it. Okay, so the temporal area of the left eye is going to be affected. So let's put it like this. Now let's proof check it by taking a look at the actual real picture. As you can see, it's correct. The basically nasal portion of the right eye and the temporal portion of the left eye. Nice, all makes sense. So the next thing is going to be the fourth one. So what does that even mean? Well, basically, after your optic tract reaches your midbrain, it will go to an area known as the lateral geniculate body. By the way, the word geniculate means knee-like. So it will reach the lateral geniculate body. And in the lateral geniculate body, we'll have two types of radiation. What do I mean by radiation? They are portion of fibers that go all over the place. So we have temporal lobe radiation and we have parietal lobe radiation, okay? So speaking about the temporal lobe and the parietal lobe, think before answering. Which one of them is located more superiorly to the other? Excellent. The parietal lobe is much more superior to the temporal lobe, okay? Good. So in this case, in case number 4, they are speaking about temporal lobe affection. Guys, everything in the place is vice versa. So when the temporal lobe is affected, the vision loss will be, the temporal lobe is located what? Up or low? Just right. Up or down? Temporal lobe. Up or down? Is it superior or inferior? Temporal lobe is, no, guys. Let me show you a brain. So temporal lobe, in consideration to the parietal lobe, is located much lower than it. Just take a look at this. So this is your temporal lobe and this is your parietal lobe. Your temporal lobe is down, your parietal lobe is up. So if you have a temporal lobe lesion, the vision loss is going to be superior because it's always opposite. And if the parietal lobe is affected, you will have an inferior visual field lesion. Remember, it will be a quarter, however. So let's take a look here. The temporal lobe affection, which is this one, temporal is inferior, so the superior visual field will be affected, and it will be a quarter, as you can see, and it follows the optic tract basically. Okay, now if we speak about this, the parietal lobe affection. Okay, parietal lobe, is it up or down? Parietal lobe, the lobe himself, is it up or down? Yes, the parietal lobe is up, it's superior. So the visual field to be affected is going to be down, which is this guy, okay? The next thing to be affected, so boom, good. So that was 5, now 6. So they write, if the posterior cerebral artery was infarcted, what will happen? You will have destruction of your occipital lobe. So the occipital lobe is supplied by the BCA, meaning that this will be destroyed. So as you can see, you will have all of your visual field gone. But what about this? Well, what is this? This is a pupil sparing. Why the pupil were spared? The answer is because it's at the area where the MCA communicate with the BCA. So when this is destroyed, the MCA will keep supplying it, so it will not fully die. Okay? So let's read a little bit what they write and then continue. So right anobia, monoocular vision loss, happens during optic nerve injury. Bitemporal hemianopsia, pituitary lesion, chiasma optica destruction due to pituitary adenoma or craniopharyngioma. Left hemianopus hemianopia, so this can be optic tract lesion which can be compressed by an anterior aneurysm. Left right upper quadranobia, quadrantanobia, which is basically destruction of the right upper visual field. That will be, okay, upper visual field, it means the lower lobe, right, which is the temporal lobe. Right temporal lesion, well, in the MCA. Okay, right lower quadranobia, I cannot see down. That means my upper brain is affected. So that will be parietal. So right parietal lesion in the MCA. Left hemianopia with macular sparing. Macular sparing, that sounds like occipital lobe affection because an infarction of the BCA, and the sparing because of the connection between the MCA and the BCA. Central scotoma can be due to macular degeneration, which is a disease of old people. So the Meyer loop and the dorsal optic radiation, what are these? This is the Meyer loop, which is the radiation going basically inside of your temporal lobe. So the lower retina, well, the Meyer loop is at the temporal lobe. So temporal lobe is located down, so it's going to be lower retina, but upper visual field. So remember, we have visual field and we have the retina. Lower retina means upper visual field, okay? So, lower retina loops around the inferior horn of the lateral ventricle. Why do we even care about that? Well, because if your lateral ventricle in somehow becomes overly dilated, it can compress it. Okay, dorsal optic radiation, superior retina, but since it is from the parietal lobe, it will see the inferior visual field, right? Because it's up, it can see down. So it takes shortest pathway via the internal capsule, which is basically a white matter of the brain. Whew, that was a lot. I highly advise you to do this 3 or 4 times. Just keep playing with it. Cut one section and ask yourself what will happen. And like make 2 visual fields and tell yourself, okay, let me cut it here. What will happen? Okay. So first of all, I have cutting it here. The problem obviously is going to be at the right side in both visual field, right? Then I ask myself, is it parietal or temporal? So it's parietal, it's the lower lobe. So which portion will be affected? The upper quadrant, not the lower quadrant. Why? The parietal is up, so the lower quadrant will be affected of the visual field. Okay, so try to keep these together. Okay, everyone, so let's take 10 minutes break and I will see you in 10 minutes. Hello everyone, welcome back. So let's continue with this. So next thing, cavernous sinus. We just spoke about this guy. So let's take a look first of all what goes through it. We have, this is the cavernous sinus, of course. Internal carotid, cranial nerve number 3, 4, 5, and 6. So cranial nerve number 5, V1 and V2. This is ophthalmic and this is the maxillary. Do you remember the ophthalmic division through which opening of the skull does it go out? No, I tricked you. No, superior orbital fissure. Superior orbital fissure, this will be V1. The V2 is going to be foramen ovale, and the last one will be rotundum. Okay, so what I want you to know now is more divisions here that we have as well: the oculomotor nerve and the trochlear nerve and the abducens nerve. These 3 have something in common. All of them are responsible for the movement of the eye. However, the first one to be knocked out in case of internal carotid artery dissection or enlargement is going to be number 6. Absolutely correct. So, cavernous sinus, a collection of venous sinuses on the either sides of the pituitary gland. the blood from the eye and superficial cortex, and yeah, it goes to the cavernous sinus and then to the internal jugular. Basically, from your eye and from your brain, all of the blood will drain to your cavernous sinus and then to internal jugular and then to the common jugular and then to the brachiocephalic and then to your superior vena cava. Okay? So, cranial nerve number 3, 4, 5, 5, and 6, plus postganglionic sympathetic pupillary fibers, which come, if you remember, from the hypothalamus to the T1 of the spinal cord, then moved as a plexus around the internal carotid artery, and then back to the face. So yeah, sympathetic pupillary fibers en route to the orbit all pass through the cavernous sinus. Cavernous portion of the internal carotid is also here. Cavernous sinus syndrome. It presents with a variable ophthalmoplegia, and it's basically going to affect the cranial nerve number 3, 6, 4, depending on how bad the thrombosis will occur. Decreased corneal sensation can occur as well. Why? Because the ophthalmic division is messed up. So no sensation of the eye. Horner syndrome can occur. Why? Because of the affection of the sympathetic pupillary fibers. However, can somebody tell me this Horner syndrome, in case of the cavernous sinus syndrome, will the patient have anhydrosis of the face? Yes or no? He will not have anhydrosis of the face because it happens in the third order neuron. That is absolutely correct. So, and an occasional decrease of the maxillary sensation because of the affection of the maxillary branch. Secondary to pituitary tumor, because this can just enlarge and push these guys. Also, carotid cavernous fistula, which can lead to a mass that it's going to cover the whole thing. Or a thrombosis of the cavernous sinus due to an infection. Okay, so cavernous sinus syndrome is something that can affect the cavernous sinus. It can be one nerve, it can be all of them. Most likely on the exam, they will give you somebody with a dissection of the internal carotid. What is the cause of dissection of the carotid? Yep, trauma, but this is a nice way to say a slap. Yes, it's actually a slap, not a bunch. Bunch will break your inferior orbita, right? But a slap will lead to dissection. Yep. Okay, intranuclear ophthalmoplegia. Nice. The last topic in pathology of the CNS, and then tomorrow we'll start with pharm. Pharm is cool. Bit difficult though, especially the anesthetic. Nobody likes them. Anyway, so let's take a look. And by the way, guys, see this page before we do it tomorrow. This is one of the pages you have to print and put in your bathroom because it's just like too much. So anyway, speaking about the pharma, of course. So now we speak about the multiple sclerosis, intranuclear ophthalmoplegia. There is a structure made out of white matter called medial longitudinal fasciculus. It has so much white matter and it's located in the CNS. So the white, it's myelinated, but by which cell? What do you think? Which cell myelinates it? Oligodendrocyte. That is correct. So which disease leads to dysfunction of oligodendrocyte? Yep, demyelinating disorder, especially multiple sclerosis. Okay, so let's see. No, not Guillain-Barré syndrome. Guillain-Barré syndrome cannot. Why? Since you put it, you have to tell me why it cannot be Guillain-Barré syndrome. Yes, because Guillain-Barré syndrome only affect the peripheral nervous system and multiple sclerosis only affect central nervous system. Correct. So MLF, its main function is to connect the cranial nerve number 6 and the cranial nerve number 3. So the idea is coordination of movement. So if you want to look to the right, okay, let's look to the left. If you want to look to the left, this guy will contract, which is the lateral rectus, and then there will be something like this. The cortex, here is the cortex, right? This is our frontal visual field. Eye field, sorry. It wants us to look to the left. Okay, so how to look to the left? First of all, it's going to fire. Firing will go all the way to the paramedian pontine reticular formation, and that is going to activate two nuclei. So the paramedian pontine reticular formation is going to activate the abducens. That will make you look abiduct your eye, looking laterally, and in the same time the MLF fibers going to be activated, and that will activate the oculomotor nerve, making the medial rictus gets contracted as well, and that will lead to adduction of the right eye. So both eyes are going to look to this side. Wow, that's cool. Okay, let's speak about a person with multiple sclerosis. So the MLF is destroyed. Why? Because it has a huge amount of white matter. So you tell him to look to the left. His left eye, okay, your brain tell you to look to the left. So the info will come from the brain, the BPRF, and then to the abducens nerve. This one will look to the left, no problemo. What about this eye? For this eye, it will not. Why? This is activated. This is activated. This is activated. This is destroyed. This is unactivated. This is unactivated. So this eye will look to that side, but this eye will be still looking in place. So, okay, good. If we speak about, let's see what they write for us. They write that MLF, or medial longitudinal fasciculus, is a connection between the cranial nerve number 6 nucleus and the cranial nerve number 3 nucleus. It coordinates both eye movement in the same horizontal direction, which means right and left. Highly myelinated, and why? Because it must communicate really quickly between the cells, and myelination helps with conduction. Lesion may be unilateral or bilateral. If it was, it can be seen with multiple sclerosis or with strokes. So yeah, why is in multiple sclerosis? Because it can affect the most highly myelinated area of the brain, which is the MLF. Lesion in the MLF, intranuclear ophthalmoplegia, is the pathology. What does that mean? Intranuclear. Internuclear means it's between the nuclei. That's correct. The MLF is between the 3rd and the 6th cranial nerve nuclei. So it's intranuclear. Okay, so the next thing they write here is the following. Internuclear ophthalmoplegia, a conjugate horizontal gaze palsy will occur as well, and lack of communication, such that when the cranial nerve number 6 is activated, the ipsilateral lateral rictus will be activated, but the contralateral, which means on the other side, the cranial nerve number 3 will not be activated. Why? Because the MLF is not working. So there will be abiducting eye display nystagmus. What does that mean? So this eye will look to this side fully, and this eye will be like just shaking, right? Okay, so cranial nerve number 6 overfires to stimulate the cranial nerve number 3, making it, yeah, it's kind of similar to strabismus, I agree. So, however, the convergence is normal, which is if you tell him to look to this side, if you both eyes, medial rictus need to look medially. Why? Because there is no communication between the two, right? This one is looking here, this one is looking here, third cranial nerve is here, the third cranial nerve is here. So convergence is going to be normal, but it's the idea of looking laterally that you will have the problem. When looking to the left nucleus, when looking to the left here, the left nucleus of 6th cranial nerve is going to fire, making the lateral rectus of the left eye looking laterally. And then this will going to stimulate the oculomotor nerve through the MLF to activate the medial rectus to look to that way. If the patient has MLF dysfunction due to multiple sclerosis, the medial rectus cannot be stimulated, and thus you get intranuclear ophthalmoplegia. Okay, directional terms. Right intranuclear ophthalmoplegia and left one. It refers to the eye that is unable to adduct. This is super important. They can show you a picture and literally ask you, which MLF do you think will be affected? And the answer is the same one that the eye cannot adduct. Meaning, the MLF in this picture, is it on the right or is it on the left? The answer is, it's on the right. Why? Because the adduction is on the right defective. So the ML left that is affected will be on the right. If the adduction was here dysfunctional, that will be the left ML left dysfunction. Okay? So it's always about where is the adduction is messed up. Okay? And that's pretty much it for the eye. Next class we are going to speak about pharmacology. There is plenty to cover. I highly advise you to print this page because a lot of mechanism of action, and then we'll keep pushing. So see you guys tomorrow. Yes, see you guys tomorrow at our usual time. Goodbye, everybody.